Hello, let's discuss pancreatic neuroendocrine neoplasms. There are some times in baseball when you know you're going to get a fastball. Maybe it's a 3-0 count, maybe it's a 2-0 count. You know the guy is going to throw you a fastball right down the middle of the plate just to get a strike across. Maybe he doesn't have his curveball, he's been spiking it in the dirt. So this SDL, I want you to approach it like a 2-0 count. You know you're going to see a fastball. They are going to give you an easy diagnosis. There are only a very limited number of ways that they can ask questions about these very specific neoplasms. So understand the cardinal symptoms associated with each, and you've got yourself 5 points on test day. Here is how they like to ask these questions, a complicated variant of it. 40-year-old woman presents with constipation, severe burning abdominal pain. So she's tried several OTC antacids that don't really work. And what they're getting at with this question is they want you to diagnose a gastrinoma. So you do, but then you go down to the answers and gastrinoma is not there. So you're like, uh-oh, you see a bunch of men's syndromes. And so this question's requiring you to understand that pancreatic neuroendocrine tumors are associated with multiple endocrine neoplasia 1. So don't forget that. Now let's get into the tumor specifically. First, you have the insulinoma, which accordingly secretes insulin. So you'll see a low blood glucose as it gets pushed into cells by the insulin signal and the upregulation of GLUT. This is associated with MIN1, and you'll see diagnostically Whipple's triad, which means the patient will have a severe degree of hypoglycemia under 50 mg per deciliter of glucose in the blood, and their symptoms will be relieved when you administer glucose. So we're going to treat this with diazoxide, which opens pancreatic potassium channels in the cell membranes of beta cells. And so whenever beta cells get depolarized, they release insulin. So this just hyperpolarizes beta cells so that it's tougher for them to mount an action potential, and thereby diazoxide inhibits the release of insulin. A gastrinoma, obviously there will be a high degree of stomach acid because when this tumor puts gastrin into the bloodstream, it circulates back to parietal cells, which then pump out hydrochloric acid into the lumen of the stomach, and there's your stomach acid. So this gastrinoma might be located in the pancreas, but it's actually most common in the duodenum where 70% of them occur. Peptic ulcer disease is going to occur over time. We know that that's going to be the most agitated symptomatically in between meals, but then if it's in the duodenum especially, the symptoms are going to go away when the patient eats initially because their pyloric sphincter is going to close and there's going to be no release of any stomach contents down into the duodenum there. But then when the sphincter opens back up and food enters into the duodenum, then the symptoms get aggravated again. So this gastrinoma is also associated with multiple endocrine neoplasia 1, and you're going to diagnose this with a nasogastric tube to measure the acidity of the stomach, and you can also diagnose it with a secretin stimulation test. And we're going to treat it with a proton pump inhibitor, that's omeprazole orally or pantoprazole IV. A glucagonoma, if you have a lot of glucagon coming from a tumor, you expect there to be a high degree of blood glucose because glucagon pulls glucose out of cells and puts it into the bloodstream because glucagon is correlated with activity. And when you're active, you need fuel, that being glucose. So the biggest symptom here is going to be a big time rash, and it's called necrolytic migratory erythema. And this just murders skin. It is very red, it is bumpy and scaly, it doesn't look anything like poison ivy, you know, much, much worse. But not only do patients have a rash, they are also at a higher risk for deep vein thrombosis. So I want you to remember both those big things. You're going to treat this with octreotide. A somatostatinoma, well, what is somatostatin? Well, when I think somatostatin, stat, I think stop. Sketchy Farms got a big old stop sign for somatostatin. We know that octreotide is a somatostatin agonist. So if you've got a lot of somatostatin that inhibits the production of certain GI hormones, you're going to have lower levels of things like cholecystokinin. And so if you don't have cholecystokinin, what that means is that you've got an impaired biliary response to food. So you're not going to be pushing bile out into the duodenum. And if you're not pushing bile into the gut, well, then you're going to have some fat malabsorption because you need bile salts to kind of sequester all the fatty acids that are in the food that you eat and move them closer to the brush border of the gut, because remember, fats are not water soluble, and so they cannot easily cross the mucosal through the mucosa of the gut lining unless they're wrapped in an amphipathic package, which bile salts provide for them. So if you don't have bile salts, you get fat malabsorption, you'll have steatorrhea, you'll have a little bit of diarrhea here, might see gallstones, and finally, this is associated with NF1, which is neurofibromatosis 1. And the NF1 gene codes for the neurofibromin protein. And if you have this NF1 syndrome, you're going to present with cafe au lait spots, which is just areas of hyperpigmentation. You're also going to have some cutaneous neurofibromas, which show up as kind of warts or bumps all over the skin of the body, particularly on the back and torso. And you're finally going to see Lisch nodules, which are hamartomas of the iris. And a VIPoma is the last of the 5 different neoplasms we're talking about in this lecture. You have a ton of diarrhea because VIP, that is not very important person. That is vasoactive intestinal peptide. So vasoactive, if you got a lot of VIP, then you are going to be sending food through your gut very, very fast. It won't have enough time to be able to be absorbed properly by the small intestine. It'll just go straight through. So you'll also have hypochlorhydria, which is the opposite of gastrinoma. You might see a diarrhea in gastrinoma as well due to the acidity of the food that is going into the small intestine. But in this case, again, you're going to have a low stomach acid content. Now, the degree of diarrhea can get so bad in a VIPoma that the patient can get dehydrated, and it can even get so bad that it can deplete your volume severely enough to cause a pre-renal azotemia, and that's a volume-dependent kidney failure. So we will also treat the VIPoma with octreotide. That's the big ideas here. Let's fly through this SDL and hit anything that we didn't see on the slides. Here's your endocrine pancreas. Not in this SDL, but very soon in the diabetes SDL, you're going to have to make the call between type 1 and type 2 based on histology. So type 1 diabetes mellitus is an autoimmune disorder. So you will see lymphocytes all over the pancreas in that case, especially in the islets of Langerhans. But in type 2 diabetes mellitus, there is no autoimmunity going on there. Instead, you will see amyloid deposits building up in these beta cells in the islets of Langerhans. So all islet cell tumors, neuroendocrine tumors, are of neuroendocrine origin. So that means that they come from the stem cells that line the pancreatic ducts rather than the ductal cells themselves. So because they're neuroendocrine tumors, we're thinking that they will stain with things like chromogranin A and maybe neuron-specific enolase and that good stuff. These are very rare tumors, which is why you might be lucky to see 2 questions on these, let alone 1 on your board's exam. There is no age predilection. They can arise at any age. And one more time, they arise from the multipotential stem cells that line pancreatic ducts rather than the ductal epithelium themselves. And they do not arise from the islets of Langerhans. So they are no longer referred to as islet cell tumors. There are a handful of inherited familial disorders that are associated with the development of pancreatic neuroendocrine tumors. The foremost being multiple endocrine neoplasia number 1. So you're going to remember this by your P's. You're going to have a primary hyperparathyroidism. You're going to have pituitary tumors, typically adenomas. And then you're also going to have your pancreatic neuroendocrine tumors, that being the 3rd P. So MIN1 to MIN2A to MIN2B, you've got 3 P's, 2 P, and 1 P there. So remember that and learn those. Also, von Hippel-Lindau disease. Remember that this is the VHL gene coding for a protein whose job is to ubiquinate and thus get rid of hypoxic-inducible factor 1 alpha in the cytoplasm. And so if you're not getting rid of HIF1A, what that means is you have too much of it. And so, well, what would too much of a protein called hypoxia-induced factor 1A do? Well, if it's produced in response to hypoxia, it probably has something to do with the stress response to hypoxia. And how do your tissues respond to hypoxia? With angiogenesis, they want to grow new capillaries to try to make some anastomoses to get some blood into these regions that are ischemic and hypoperfused. So that's exactly what this excess of HIF1 alpha does. And that's why von Hippel-Lindau disease presents characteristically with hemangioblastomas, but also renal cell carcinomas and pheochromocytomas. And remember that your kidneys are very vascularized organs. Your kidneys receive 25% of your blood flow every minute. And so there is a ton of potential for this hypoxia-induced factor to kind of go wild with angiogenesis in an organ that has so many blood vessels to start with. So that's why those organs, the kidneys and adrenals, get affected in VHL disease. Then we have neurofibromatosis type 1. You've got those Lish nodules in the eyes. Those are hamartomas. Those are architectural abnormalities, not tumors. You also see those cutaneous neurofibromas, and you're going to see the cafe au lait spots. And then finally, tuberous sclerosis. You're going to see bumps, essentially. It codes for the hamartin protein, the TSC1 gene does. And then you have TSC2 that codes for tuberin, and both are going to present with things such as cardiac rhabdomyomas. That's very characteristic. That means you just have a bump in the heart, and a rhabdomyoma is a benign tumor of skeletal muscle origin. You've got these non-secretory pancreatic neuroendocrine neoplasms. Specifically, the insulinoma is particular to tuberous sclerosis. And just to hit it once, the somatostatinoma is characteristic of NF1. So bumps all over your skin, bumps on your heart. That's TSC, and it is autosomal dominant. VHL is autosomal dominant. MEN1 is autosomal dominant, and NF1, I think, is autosomal dominant. I'll go back to that in the end and look that up for you. So table, not telling you anything we didn't talk about already. Insulinoma, fasting hypoglycemia because you have so much insulin. Maybe it's MEN1, maybe it's TSC if they ask you about a familial inheritance pattern. MEN1 particularly likes to present with multiple insulinomas, so a very, very, very low blood glucose there. Fasting hypoglycemia. So then the SDL runs through hypoglycemic symptoms, and this is a good one to have in your pocket. Reduced brain sugar is going to lead to fatigue, blurred vision, your eyes demand a lot of energy, confusion, seizure, and possibly even coma. And then also the adrenergic effects produced by the catecholamine response to low blood glucose are going to amplify the symptoms of fatigue, weakness, and headache. And they're also going to give patients some sort of sweating, possibly a tachycardia as well. That's hypoglycemia, and it does not take a long fasting period to dip into hypoglycemia for a patient that has an insulinoma. Whipple's triad comes up again. That seems like more of a ClinMed question to me. So the most common cause of hypoglycemia is going to be exogenous sulfonylureas, which are going to work as potassium channel blockers that trigger insulin release. And so you ought to be able to inference that this is a drug that we give to patients with diabetes in order to get a little bit more insulin out of their beta cells. And they are particularly good in type 2 diabetics because type 1s aren't making a lot of insulin to start with. We can do a 72-hour fast test. That's not particularly relevant. This is an obvious clinical diagnosis. One more time, diazoxide is going to do the total opposite of those sulfonylureas. It's going to open up potassium channels to hyperpolarize beta cells and thus inhibit insulin release. And so that's how we're treating an insulinoma. A gastrinoma likes to present with peptic ulcer disease. We're going to call that Zollinger-Ellison syndrome. You've got a whole lot of gastrin and nobody can do anything about it. Association with MEN1. Now, gastrin is going to bind to cholecystokinin B receptors on parietal cells to get hydrochloric acid going into the stomach, and chief cells as well to get pepsin going into the stomach, and that's a preprotease. Gastrin is released from G cells, easy, in response to gastric distension. The vagus nerve can also stimulate it. And it's also responsive to the presence of protein within the gastric lumen. So most gastrinomas do form in the duodenum, and gastrinomas, just about all of them form in this gastrinoma triangle, which extends from about the merging point of the hepatic and cystic ducts into the common bile duct, all the way down to about the ligament of Treitz, where part 4 of the duodenum meets part 5, and then way down here to some ambiguous point at your transverse colon, and that is what is defined as our gastrinoma triangle. So the diagnostic of choice for this is going to be the EGD, the esophageal gastroduodenoscopy. I butchered that, but that's exactly what you're going to get. You're going to put a camera on a tube straight down the mouth, and you're going to check out the duodenum. So patients will present often with diarrhea just because their stomach is so acidic and your small intestine doesn't want to absorb food if it's below a certain pH. And so it'll just let the food go, you know. And so with that poor absorption, poor liquid absorption as well, you're going to have a lot of diarrhea. And you're going to differentiate that from a VIPoma just based on the stomach acid content. And that's easiest done through an NG tube if you're in the hospital. So GERD symptoms as well. Patients have a lot of heartburn. Patients have stomach pain. The secretin stimulation test is going to differentiate a gastrinoma from other causes of hypergastrinemia. So we don't know why, but secretin is going to really ramp up the production of gastrin by gastrinoma tumor cells. And so patients get secretin and then their gastrin goes from 0 to 1,000 real quick. Treat them with PPIs one more time. The glucagonoma, you're going to have a fasting hyperglycemia. It's pulling glucose out of your cells, putting it in blood. You're also going to have a hypoalbuminemia. I'll see if I can remember why that is. So you got a dermatitis, that's your necrolytic migratory erythema. You get DVTs, you get diabetes. Why you get diabetes? You'd think that'd be kind of counterintuitive. You got a bunch of glucagon, but really you're going to get diabetes because you will have such a high degree of hyperglycemia that alongside all the glucagon that you're making, you will also get a lot of insulin. So remember, those two things aren't mutually exclusive. You can have a lot of glucagon and a lot of insulin. You can have a little glucagon and a little insulin. It's not like when one goes up, the other automatically goes down. They can kind of compete with one another. And so you're going to get a very high degree of insulin whenever you get this high blood glucose, but glucagon will stay high due to the tumor. There's the histology of the skin within necrolytic migratory erythema, necrosis and separation of the upper layers of the epidermis, giving rise to clefting or vesiculation. What else could give you a vesicular skin appearance? I'm thinking herpes 1 or 2, herpes simplex. I'm also thinking there's a Staph aureus exotoxin that's going to give you scalded skin syndrome. And so what the vesiculation is just fluid edema pooling in between layers of epidermal keratinocytes that have had their tight junctions separated and they have ripped apart, and now fluid transitate just kind of fills in the space in between those cells. Glucagon promotes protein degradation, so that's your hypoalbuminemia. Your body thinks that you are in the fasting state. Now, you're not in the fasting state. You just have a glucagon tumor, but your liver doesn't know that, so it's going to be breaking down every protein on the block, just trying to get some substrate for gluconeogenesis, because that's what glucagon is going to trigger. Big time rate of metastasis. You get asked what's the most metastatic of all these tumors. I think it would probably be the glucagonoma, unless the somatostatinoma proves me wrong here. Somatostatinoma, big NF1, neurofibromatosis 1 correlation. You'll see gallstones because there's no CCK. You'll see steatorrhea because there's no CCK. So they might ask you about, well, what's the effect on blank hormone if you have this tumor, you know? So that should be easy. There is a high incidence of Somoma bodies in the duodenal lesions of patients with neurofibromatosis type 1. And so let's take a minute and talk about Somoma bodies. You are also going to see these dudes again, or you have seen these dudes previously in what sort of cancer of the thyroid? So I'm thinking papillary there. So we got this nice little mnemonic. It goes, let's see, Somoma bodies. And we got a big P, a big S, a big M, and another big M. So the P stands for papillary. That means papillary carcinoma of the thyroid or the kidneys, either of those you see Somoma bodies in. The S stands for serous cystadenocarcinoma of the ovaries, and that's pretty bad. Cancer tends to be bilateral. And the 2 M's stand for number 1, meningioma. That's up in the meninges around the brain, the dura mater and arachnoid mater. And the other M stands for mesothelioma, which is a pleural cancer of the lungs. 2 types of somatostatinoma, pancreatic and duodenal. Pancreatic is going to give you a triad of diabetes, cholelithiasis, and steatorrhea, whereas duodenal somatostatinomas tend to be asymptomatic largely. So I'll write that out here so that you too can make an annotation wherever you take notes. And remember that the duodenal somatostatinoma likes to not have any sort of hormonal symptoms at all. Instead, it's just going to compress your GI tract and maybe one of those arteries, maybe the pancreaticoduodenal artery, maybe like the hepatic artery behind that, a little superior to it, can get compressed by the mass effect of this tumor. One more time, NF1, 75% of tumors have metastasized by the time diagnosis is made. So maybe this one metastasizes a bit more than the glucagonoma. Treatment for all these, again, you're just going to cut them out. Finally, the VIPoma, vasoactive intestinal polypeptide, is going to activate cyclic AMP, which is going to push ions out of epithelial cells lining the GI tract. And so you get an efflux of electrolytes, and water follows all of those ions, and then there's your diarrhea. So it's also going to trigger smooth muscle relaxation. And so what that means in the gut is that your bowels go from contracting and trapping food in a particular locality so that it can be absorbed properly, to not doing anything at all, to just let that food go straight through your gut as if it's like 10-year-old you on a big water slide. So half of these are malignant, poor prognosis. Very bad diarrhea, again, is the symptom. Hypochlorhydria is another one. Patients might have these big, drastic ion disturbances, hypokalemia, low bicarb, hyponatremia even. Probably not hyponatremia because you'd reabsorb sodium at the expense of bicarb. That's where you get the low bicarb. And then you'd treat it with octreotide. So that's this SDL. Really nothing going on. You're going to get a fastball, go out there, hit a double in the gap.